Good day, dear colleagues. I'm glad to see you here in our webinar of Crystal Vision Eye Clinics by Professor Igor Aznaudan. Today, our talk will be about tips and tricks in control of myopia in kids. And it is a very important question nowadays because the amount of kids with myopia is going much bigger. And during the next few 20, 30 years, it will for sure grow. So today we will discuss about different methods of myopia management, which works, which not, and what we as pediatric ophthalmologists can do to make vision kids much more better and without less complications. So let me introduce myself. My name is Dr. Sati. I'm an ophthalmologist and Director of Development for Crystal Vision Pediatric and Adult Eye Clinics in Bahrain. So, as we know, many current articles on myopia contain a citation to the 2016 study by Holden, which discusses the increasing prevalence of myopia worldwide. At the time of the study, approximately 23% of the world's population had myopia, with a predicted increase to 50% by the year 2015, as we see in the graphic. The highest prevalence rates were found in Asia-Pacific countries, with East Asia, Southeast Asia, and North America, not far behind. This meta-analysis confirmed that the prevalence of myopia was high and continued to increase if no corrections were introduced. However, traditional corrections were provided ineffective. And today we will discuss different types of corrections in myopia, in kids with myopia, so that we will be able to understand which really works and what not. What is the most important to know about myopia and why we are so interested in researching different types of myopia management? It is because of the complications of myopia. And as we know, retinal detachment, myopic maculopathy, that situations can make their vision, not even in kids, but also in adults, very pure. That's why we understand that increasing their length of the eye for increasing of the myopia for one diopter make their risk of retinal detachment and myopia maculopathy much more higher. That's why we need to make myopia as less as it possible and to use all different types of myopia management for stopping the progression. So risk factors of myopia are genetic predisposition, settling down, physical development, calcium deficiency, hypovitaminosis, insufficient amount of time spent in the air, mainly during the day, and early and intensive near vision, use of computers and gadgets. So there are not one risk factor that we can name, and that's why because of the many risk factors, we should understand many other processes that we should do and we should manage during our taking care of kids with myopia. So genetic, environmental, and lifestyle factors as they have been identified. And we know that parental myopia increases the risk of myopia development. Having one myopic patient increases a child's likelihood by a factor of 3, and having two myopic parents increases the likelihood by a factor of 5, 6. So, for example, if two parents will have myopia, the risk of kids to have myopia is nearly 70 and 80%. However, genomic-wide association studies are only able to account for 8% of the phenotypic variation. With the rapid increase in the prevalence of myopia and the limited genetic variability over the same period, it is more likely that environmental and behavioral factors are responsible for myopia development. So that's why the genetic is very important, but environmental influence is we also need to account when we think about the risk of myopia in kids. Specifically, strong evidence supports that the time outdoors, light intensivity, and new work all play a role in reducing myopia development and progression. Uh, so, increasing time spent outdoors is thought to delay myopia onset because it is associated with reduced myopia prevalence. And recommendations, as we know, is 2 hours per day or 10 hours per week that the kid will be outdoors. There was consensus of WBCPOS, World Society of Pediatric Ophthalmology and Strabismus, on myopia correction methods. And there were all myopia management variations were divided into two big parts. What doesn't work or has minimal effect, and what most likely to work. So let's see. Non-correction, what doesn't work or has minimal effect, it is a non-correction. According to numerous studies, myopia under correction either leads to an increase in the progression of myopia or has no effect on its stabilization. We know that sometimes kids don't want to wear glasses, and even sometimes we can have this problem with the parents that don't want their kids to wear glasses. But as we see, when a kid have no glasses, there is more risk to have a myopia progression. In the contrary, when the kid have glasses and wear it. What also doesn't work or has minimal effect, it is bifocal correction, progressive correction, monophthalmic contact lens correction, and perforated lenses. I don't know how usually in Bahrain and other Gulf countries, kids and parents used to use perforated glasses. But in Russia, in Moscow, we have not less parents who come to us to the consultations with black glasses with these perforated holes, and they read somewhere in the internet that it can help their kids in preventing of myopia and stop their progression. So now we know that it doesn't work. What most likely to work? It is a correction methods that create peripheral myopic defocus on the retina. It is the generation DIMS, the generation HALT, contact lenses with the hypermetropic defocus, and orthokeratology. All that methods in their basis have hypermetropic defocus that we need to use during our management. So here we will see what is this peripheral defocus theory. Turn on the video, please.
With standard single vision lenses, the central zone works fine, but the periphery of the lens often projects the image behind the visual area. This can result in a signal to the eye to elongate, which increases the progression of myopia. So the Zeiss MyoVision Pro lens's active zone in the periphery corrects this defocus and in consequence can help reduce.
So as we see, there is why we say about the peripheral defocus and why these methods as HALT, DIMS, and contact lenses and with peripheral defocus and orthokeratology works. It is because they make the image to come to their retina also not only in the center but also in the peripheric parts. So DIMS technology to correct the myopic refractive error and provide clear vision is used in the glasses as Mia Smart spectacle lenses. This technology is to correct the myopic refractive error and provide clear vision. So according to this technology, the minus lens has many points of plus points that make this peripheral defocus and give us a chance to have a retinal image also in the periphery. Technology HALT creates a volumetric signal in front of the retina, slowing the progression of myopia. This technology is used in another glasses as in the Essilor company, and also orthokeratology. It also used to have this peripheric defocus, and in a recent review on myopia management interventions and their effect on vision-related, Lipson and al. Found that their progression of myopia was less in children wearing orthokeratology lenses comparing with those who wear single vision spectacles or single vision soft contact lenses. Additionally, contact lenses have been shown to improve children's self-perception compared with spectacles in terms of physical appearance, athletic competence, and social acceptance. So we understand that orthokeratology cannot be used in all kids because there are some borders of myopia and astigmatism in which we can use that. But in a big amount of kids, we can really do that. And MySight one-day contact lenses for myopia control are the only FDA-approved product proven to slow myopia progression in children aged 12 years at the initiation of treatment. So there are 1D lenses, very comfortable for kids, also have this peripheric defocus because of the structure of the lens. And wearing them give us a chance to stop progression. And when we talk about contact lenses in kids, what is very important? It is important that daily replacement lenses are preferred because of their inflammation and their need of kids to be very careful with contact lenses if it is 4 months, for example, or for 2 weeks. Parents and children should be informed about the hygiene and lens care and should be very keen in that. We need to check that the child knows how to do it in himself, at least remove contact lenses, because something can happen at school when he will be in different classes, and he needs to be very keen in wearing and removing contact lenses from eye. And the criteria for assessing contact lenses landing in children and adults are not different. So K factor is a motivation, and we know that contact lenses we always use, and orthokeratology also, in kids who are who used to have very active life, in kids who go to different sport classes, dance classes, who who are not very comfortable wearing glasses because we know that they can be very shy in that and feel themselves not very good in social life. And usual contraindications for the assignment of contact lenses is protruding eye inflammation, severe forms of dry eye syndrome, and also possible difficulties in handling lenses and emotional instability. Usually kids are afraid at the first times, but then they are going very quick with wearing and removing contact lenses. What also we use always in myopia management, no matter what type of correction we use, contact lenses with peripheric defocus, glasses with peripheric defocus, orthokeratology, it is always atropine, 0.01%. We know that it is a non-selective muscarine antagonist, and in their researchers atom 1, 2, and 3, it shows an efficiency in myopia in large number of studies. And so a concentration that we use is 0.01. We use it during many years, 2, 3, according to the year of age of the kid, and also the results of the progression. And there are practically no side effect except of allergy, and also we don't use it in kids with some problems with cardiovascular system. What is also very important to know, it is that in Crystal Vision Eye Clinic, we make vision therapy in kids with myopia using different devices. For what we do that? For making their accommodation more stronger, because as we know, in kids with myopia, accommodation is very pure. And this pure accommodation give no chance a kid to focus on different images, and that also brings to more progression of myopia. It is courses of 10 days treatment that we do in our clinic now in Manama, in Bahrain Specialist Hospital, where Crystal Vision Eye Clinic is. We can do this treatment, and also we work with practically all insurance companies. And this treatment is done 3-4 times in a year to prevent the onset and the progression of myopia. There are different devices, as you see in the slide, development of accommodation by IBTs of MUDs, photomagnetic stimulation, vacuum massage, computer orthoptics, electrophoresis. And indications for conduction is progressive myopia, congenital myopia in kids with amblyopia, lower rates accommodation, and also a stenopathic complete. Sometimes even when we have some problems with accommodation in kids because of some nervous situation, maybe even psychological situations in school, we see that their accommodation is going also lower. This treatment also can help them to have a good vision and no problem with accommodation. Also, myopia management is not only treatment and correction, but it is also diagnostic that we need to do every year, sometimes even twice a year, to understand where we are and what is their low rate of progression and what will be next. So we always do A and B scanning in kids with myopia to understand the length of the eye, and we understand that the increase of more than 0.16 millimeters in 6 months or 0.32 per year, it is a fast rate of progression. And we need to be more careful with these kids, to see them more often, maybe once in a month or once in 2 months, to make maybe more often the vision therapy, and maybe to change their type of correction, and so on. Also, very important to do a fundus examination with Goldman lens, because not only adults but also kids have different problems in periphery with retina, and we need to detect them in time for having a chance to make a laser coagulation in kids if it is needful. And in our clinic, in Crystal Vision Eye Clinics by Professor Igor Aznouran, we have a Visio Care. It is a comprehensive approach to the problem, not only in myopia, but also in hypermetropic kids, amblyopic kids. And in Visio Care, treatment of myopia includes have all that concept that we're talking about. It is a glasses, soft contact lenses, orthokeratology, right correction with the peripheral defocus, atropine 0.01, vision therapy, and also if a kid have a congenital myopia, usually it is one side, minus 12, minus 13, minus 16. And if it is stable, and usually congenital myopia has no progression, we also used to do refractive surgery in kids with this one side congenital myopia for giving them a chance to see much more better. So thank you for attention. I hope that our lecture today was interesting for you, and if there are any questions, please you can put it on chat or in questions. I will be happy to answer on them. Also, I want to say that we are open to all doctors in Bahrain, Saudi Arabia, and in other countries of Gulf countries to cooperate and to help with their management of kids, not only with myopia, but also with strabismus, astigmatism, amblyopia. If you are interested in collaboration and knowing what technologies we use and how we can be helpful to each other, please don't hesitate to contact me. I think that you all have my phone number. You can WhatsApp me. If no, I will write it now in the chat. So I will be happy to help you and to say how we can be helpful to your patients with different diseases. So if no questions, thank you so much. I was happy to see you here in our lecture. Next Wednesday, we will talk about amblyopia, and the talk will have our Professor Igor Znouran about the different types of treatment of amblyopia. Thank you so much and have a good morning.